Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling chronic obstructive pulmonary disease, or COPD. Specifically, we are going to look at the acute exacerbation that can sometimes happen in this chronic condition. So let's kick it off with our practice question. As always, save on to that right answer, and we will circle back to it at the end. The nurse is caring for a client hospitalized due to an acute exacerbation of COPD. Which assessment finding would the nurse expect to find? We have an ABG showing a carbon dioxide level of 31. B, hyperinflated lungs on chest x-ray, C, improving oxygen saturation with exercise, and D, a wide diaphragm on the chest x-ray. All right, so before we get to that answer, let's dive into exactly what COPD is. To understand the exacerbation, we have to understand the underlying condition, and as always, our normal anatomy and physiology. So I want you to imagine your lungs like two soft, stretchy balloons that are designed to fill and empty easily in a healthy system. Every breath is like a smooth inhale of fresh air and then a relaxed, easy exhale. But someone with COPD, chronic obstructive pulmonary disease, these balloons lose their stretch. Over time, we've got more and more damage to the lungs, making it harder to push out old, stale air. It's like we're trying to deflate a balloon that's become stiff and overfilled, and no matter how hard you try, that air is just lingering. It is trapped. So now, technically, COPD is an umbrella term. It includes chronic bronchitis and emphysema. These are both chronic obstructive pulmonary diseases. So in the emphysema branch, the alveoli, or those tiny little air sacs where we get our gas exchange, get destroyed and lose their shape. Okay, so these balloons are all distorted. They're not nice and round anymore. They're like shriveled up little raisins. Their walls thin out and pop. We got less surface area for that gas exchange, so less oxygen coming in and less carbon dioxide going out. Now, that is a big problem, as we're going to see throughout this episode, because our body relies on oxygenated tissue and removing CO2. It literally relies on that oxygen so we know when to breathe. We'll circle back to that because we got a whole second little branch here. That's emphysema. But the other type under that COPD umbrella is our chronic bronchitis. We got another layer of trouble here. In chronic bronchitis, the airways are inflamed and swollen. So those airways, that bronchi, those bronchioles, the body starts making way too much mucus because of this inflammation. And that mucus clogs up the airways that are already inflamed and swollen. We got gunk clogging them up. So we have now stiff, stretched out air sacs. Those balloons don't want to deflate. And then gooey, inflamed airways. Not a good combo when you're trying to breathe. Okay, so emphysema, we got those floppy alveoli. Chronic bronchitis, we also add the inflammation in the mucus. For both of those, the key here is that we're not getting good gas exchange. It is hard for oxygen to go in. It is hard to get CO2 out because it is hard to get oxygen in. One of the hallmark signs of COPD is air trapping. Those lungs have lost their natural recoil and the airways are narrowed or blocked. So air is getting stuck inside. With every breath in, a little more air stacks on top and the lungs overinflate. So key takeaway on a chest x-ray, watch out for hyperinflated lungs. That's going to be like your key buzzword on exam. Hyperinflated lungs means we have air trapped in there. Red flag for COPD. Now, those hyperinflated lungs are pushing on the diaphragm, which can also flatten out the diaphragm So a flattened diaphragm, think of it like the lungs are puffed up so much they're pressing everything else down, is another sign. Over time, this hyperinflation leads to the probably most iconic of the COPD symptoms, and that is a barrel chest. So we define a barrel chest as where the anterior posterior diameter, fancy word for saying front to back, the front to back diameter of the chest is getting bigger and bigger and bigger with those hyperinflated lungs, and it's kind of making it more round. We should usually be wider than we are deep, but when that front to back diameter, that anterior posterior AP diameter, gets bigger and bigger, we end up more round, and they call that a barrel chest. So if you hear hyperinflated lungs, barrel chest, you better be thinking COPD. Okay, now let's get down into the cellular level here, because this all has really big implications. We need to talk oxygen and carbon dioxide. With that air trapped in those lungs, leading to the hyperinflation, leading to the barrel chest, we have poor gas exchange. It is hard to get oxygen in. It is hard to get carbon dioxide out. If we can't get carbon dioxide out, the carbon dioxide builds up. And the more carbon dioxide we have, the worst. High carbon dioxide is called hypercapnia. All right, remember that one. Say it with me, hypercapnia. You want to remember that word for your exams. And carbon dioxide is an acid, CO2 with a little minus up there, okay? So if we get more CO2, we get more acid, and our blood becomes acidotic. So on our ABG, you're going to see a low pH, all right? That's not so good. So a normal CO2, remember, 35 to 45. And with COPD, we are hanging on to more CO2, so we would expect that number to go up. 50, 60, 70, the higher it gets, the more acid we're hanging on to, the lower our pH, the more acidotic. This is a classic example of respiratory acidosis, okay? Those are some really big takeaways I want to make sure you know. So what better way to remember them than walk through a case? My example of COPD comes from a night in the ER. We had a 68-year-old woman came in through the ED. It's the middle of the night, nowhere else was open. She obviously did not want to be there. Her granddaughter had brought her in, but one look across the room and she was struggling to breathe. She was somebody that as she was walking up to the triage desk, we were like, oop, go ahead and get a wheelchair. Let's wheel her back. Even if there's not a bed, like we're going to do this right away. You could see her nasal flaring, retracting. She was tripoding, leaning over, just clearly unable to get a good breath. She was anxious, confused, the whole 9 yards. So I popped the pulse ox on her. First thing, boom, pops up on the monitor, 78. 78 on room air, dangerously low. And that helps me understand why she's confused and anxious. She's not getting enough oxygen to her brain. As soon as somebody has that hypoxia, anxiety is going to be a big time indicator. Our brain does not like being low on oxygen, okay? So we hook her up to the rest of the monitor. We start getting her history. We're, mainly talking to her granddaughter or the other nurses while I'm hooking her up. And the granddaughter gives us a basic rundown. Type 2 diabetes, hypertension, COPD, so several comorbidities here. But her granddaughter says, hey, typically we've got this under control. I've got her meds. She had a whole list of all of her meds. She took care of her grandma. So this wasn't a typical evening for them. She said, after dinner, things took a really sharp turn. They had a fairly large dinner, like steak, potatoes, all the things. They were celebrating something. I don't know what. But after that big dinner, over the next hour, she had a harder and hard time breathing until her granddaughter was like, wow, grandma's like even confused and just like doesn't look like herself at all. Time to go in. So let's get back to the client, what her physical assessment looks like. We've got that 78% on room air for her SAT. She was also tachycardic and tachypnic. Her blood pressure was fine for the time being, thank goodness, but clearly still struggling to breathe. So listening to her lungs, she is wheezing and what I would say just like not moving good air. What do I mean by that? When air is going in and out, we should hear that really nice whooshing sound where like, yeah, I'm literally moving air in and out of my lungs. So when I say someone's not moving good air, I guess a more technical way to phrase that is diminished breath sounds. Like I'm not clearly hearing, especially that air going out. It's like as it's trying to go out, it's wheezing through those tight, constricted, gooped up airways, okay? Which is very classic for a COPD exacerbation. Her airways are inflamed, air is not getting out, it's being trapped. We're not getting good gas exchange, all of the things. Normally we breathe in, air fills the alveoli, we get that oxygen in, that carbon dioxide out, and then we exhale, we push that air out, we get rid of the CO2. But this client had like a 20-year history of COPD. Her lung tissue lost that elasticity. Her alveoli were really floppy and overinflated. They were those stretched out balloons that were weird shapes. She was getting air trapped and overinflating her lungs, stretching things out, so that by the time she went to go exhale, she couldn't get the carbon dioxide out. That was leading to a retention of CO2 and acid, causing hypercapnia, too much CO2. And when we got her ABG, because, one of my nurse friends had already come and drawn labs while I was getting her hooked up to the monitor and listening to her lungs, we got a very high CO2. I think it was like 72. It was above 70, which for me is like, ooh, emergency, we've got a big problem. And then a low pH because of all of that acid, so respiratory acidosis. She also had a low PO2 level, which we would expect. She's not getting good gas exchange. She is hypoxic. That's causing her to be anxious and confused. So what do? All right, nursing interventions, let's prioritize. When we have a client who is hypoxic, she's 78 on room air, we of course want to get them oxygen. But a key takeaway from this episode is that we need to be really careful with oxygen administration when a client has COPD. Clients with COPD have been living a little hypoxic for a long time. And normally, we rely on a high level of CO2 to tell our body to take a deep breath. If I go and hold my breath here, my oxygen might start to go down, but I'm retaining CO2, and that high CO2 is what gives my brain the drive to breathe. Okay, so COPD clients, they've had high CO2. Their brain has now switched mechanisms and is relying on low oxygen to cause their body to need to breathe, to drive that need to breathe. So if I take her from 78%, pop her on 100% FiO2 and call it a day, yeah, her SATs might come up until she goes apneic. Her brain's going to be like, I don't need to breathe, I'm good, okay? That only happens with clients who have a long history of COPD and their bodies have kind of switched that mechanism. So, yeah, she's 78. You bet I put some oxygen on her. But not like a whole 100%, Venturi mask or rebreather, non-rebreather, or whatever. Like, I think I did 2 liters nasal cannula. And then we kind of titrate to get those oxygen saturations to about like 88 to 92%. We are not titrating to 100%. That 88 to 92 is going to be enough to perfuse her organs without shutting off her respiratory drive, okay? So yes, prioritize oxygen, but use those SATs and deliver it carefully. Don't overdo it. Now, going through our case here, that 2-liter nasal cannula actually did not do the trick. Just that passive little flow wasn't enough to get her oxygen up. So instead of drowning her out with a higher percentage of oxygen, we notified respiratory therapy and they initiated BiPAP, bi-level positive airway pressure. So that pushed air, delivered positive pressure into her alveoli so that we could actually push oxygen in and assist with getting the CO2 out, okay? A lot of clients in an acute COPD exacerbation, when it's really bad, we've got those really low sats, we need some pressure. So start with that nasal cannula. If it's not enough, you better call RT. Let's get some pressure going to push open their alveoli. Priority number 3, let's open up those airways. They're inflamed, constricted, gooped up with mucus. Let's use a bronchodilator, okay? For this specific client, we did a med that was like a combo of albuterol and irpetronium. Provider's choice. You may see just albuterol, irpetronium. You may have a different medication. I want to see airways opening. So bronchodilator is the class of med I want you thinking of. We are trying to relax smooth muscles around the airway, reduce bronchospasm, widen that airway. Essentially, I'm just trying to make it easier for air to go in and especially out, okay? We want air getting out so we're not hyperinflated, holding on to CO2 and getting more acidotic. Another med we can give to help with that inflammation, the next thing we did was a corticosteroid. Reduces inflammation. In the ED, we did an IV steroid. This client got hydrocortisone, so that worked really fast to get the inflammation down, and it also helped reduce mucus production. So we get more airway open, more oxygenation, more carbon dioxide out to help with our respiratory acidosis. So lots of meds, but non-pharm too. Think about the other things we can do to open those airways. We need good deep cough and suction. Mucus is plugging up. We got poor expiratory effort. We need to clear secretions. So we're going to do some coughing. We might do some chest PT, good suctioning. Again, your respiratory therapist can help here. And with these interventions, we're always following up to see if our interventions work, right? How are we going to know if our BiPAP, our chest PT, our suctioning, our albuterol, our corticosteroid, how are we going to know if it's working? First, assess your client for their work of breathing, right? We want to see that respiratory effort go down for this client pretty much right away once we got that albuterol on board. That made a huge difference for her. Bronchodilation, her wheezing went down. She was having less retractions and nasal flaring. She was just more comfortable pretty quickly. So then second assessment, we watched her pulse ox start to come up. She went from 78 to 82. We got her to about 90. Again, with that BiPAP, the nasal cannula wasn't cutting it. We had to have some pressure to push those alveoli open. So we're watching that O2 sat for immediate response to our airway interventions, getting that BiPAP on. Okay, but the source of truth here is going to be a lab, a specific lab. Do you know what lab we're monitoring? ABGs. All right, your arterial blood gas needs very close monitoring. That's going to kind of guide our therapy and help us make adjustments. What do we want to see? We want that CO2 coming down, of course. We want to see, yeah, our airway clearance, we're opening up those bronchioles, we're getting better gas exchange so that we get rid of the carbon dioxide, and that will help us resolve the acidosis. So very close monitoring of those ABGs. Now, this client, she went to the step-down unit because she didn't need intubated, so we didn't have to send her to the ICU, but she was on some pretty good BiPAP, so she went to step-down. She was actually on BiPAP for 3 days. Her oxygen stabilized pretty quickly. Her work of breathing came down while she was still with me in the ED, but she was still acidotic. She had been hanging on to CO2 for days, if not weeks, so it took a little bit to get all that out of her system, get it normalized, and weaned off the BiPAP. Okay, so the key takeaway I want you guys to get here with a COPD exacerbation, we need to support that ventilation. Likely you're going to need some pressure. We want interventions like albuterol and steroids to open those airways and reduce that inflammation. But make sure you're keeping a close eye on how much oxygen you deliver. That's what I want you walking home with, okay? If we give them too much oxygen too quickly, specifically the FiO2, if we're turning that up crazy high, we will take away their drive to breathe. Their body is dependent on low oxygen telling them to take a deep breath because they've been living hypercarbic for so long, okay? So use oxygen, But be smart about it. Watch those O2 sats and know that like 88 to 92% is good for COPD. So all that being said, let's circle it on back to our practice question and see now if you know the right answer and why. We have a client with an acute exacerbation of COPD. What assessment findings would you expect? We're looking for what you would expect with COPD. Is it A, an ABG with a CO2 level of 31? B, hyperinflated lungs on the chest x-ray? C, improving oxygen sats with exercise? Or D, a wide diaphragm on the chest x-ray? Okay, what would you expect? Say it out loud in your car on your walk to class, jot it on your notes. What is it? It is B, that hyperinflated lung. Classic finding. Remember, that's what leads to the barrel chest because our lungs have lost their elasticity and we can't get air out. That air trapping overinflates the lung and we get them hyperinflated. Our other choices here. A, that CO2 of 31. Normal is 35 to 45, and we're holding on to CO2 because we can't breathe it out. So a high level, over 50, really. I had a level of 72 in our client today. That's what we would expect. Hypercapnic, not the other way around. Okay, C was improved oxygen with exercise. I would love that for us, but I think you guys know that's not what we will see in COPD, especially when we have that exacerbation. We've got inflamed, clogged up airways. So if they go and exert themselves more with exercise, their O2 sat is gonna get worse. And lastly, D, we had a wide diaphragm. If you picked this, you're confused with a flat diaphragm. Remember, the diaphragm flattens out because of our hyperinflated lungs causing that barrel chest. So we don't see it wide, we see it flat. All right, that's what I've got for you on COPD. Big picture, you're thinking about that COPD exacerbation, think trapped air, increased work of breathing, poor gas exchange, leading to that respiratory acidosis. Give them oxygen, but be real careful with it. Help open up those lungs. Your goal's going to be making it easier for your client to breathe. You might give them oxygen, but be real careful with it. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.